Good afternoon or good morning, depending on what time zone you are in today. My name is Derek Dorado. I work with AZZLY as the Senior Director of Enterprise Solutions. I wanted to thank you and everyone that's joined the webinar today. We are very excited to host this webinar. AZZLY and DrFirst have been in a preferred partnership together for over a decade, and they are very experienced in understanding of the regulatory changes going on in today's opiate epidemic. And today's topic for the webinar is improving e-prescribing safety and efficiency for behavioral health and addiction treatment providers. And we are very pleased and proud to have an exceptional panel to share what new regulatory changes are facing behavioral health and addiction prescribers in 2022. Today's panelists are the Honorable Dr. Andrea Barthwell. We also have Heidi Polek, and lastly, Maria Gray. Today's agenda is we're going to go ahead and start off with Dr. Andrea Barthwell, following Heidi's presentation on the EPCS and PDMP mandates. And then following that will be Maria, who will be sharing today how today's modern electronic health record can bridge the gap between EHR and prescribing through a single sign-on functionality. And then we'll be following after all of the panelists discuss and go through their presentations, we'll be following that with time to go through questions. So today's learning objectives are the following. By the end of the presentation, you should have a good understanding of the opiate epidemic. You'll have an understanding of the medications being used to treat the opioid use disorder. You'll have an understanding of the history of EPCS and why it is mandated. We'll also have the understanding of the upcoming regulatory mandates and how to prepare for them. And you'll also have an understanding of how AZZLY and DrFirst are your partners in that preparation. And lastly, you'll have a better idea of the best practices and resources for EPCS and PDMP use. So without further ado, we're going to go ahead and start off with our first panelist, Dr. Barthwell, who will be going into her presentation.
Thank you, Derek. Good morning, everybody. I'm Andrea Barthwell, and I have over 40 years experience in treating opioid use disorder and substance use disorders in general. And what I hope to do today is to talk about the challenges that we're all experiencing and facing in managing opioid use disorder, no matter where we work, give some pearls on how to prepare your patients for that treatment, how to document that treatment, and having been an AZZLY customer before I became their advisor and strategist, I know how useful the tool is in helping me manage the care of patients. Could I have the next slide, please? So I just want to remind you, drug use is a preventable behavior, but addiction is a fundamental yet treatable disease of the brain. Alan Leshner, one of the former heads of the National Institute on Drug Abuse, used to teach us this during the 80s. The problem with addiction, unlike other diseases, is that it is often not viewed by the public as a disease of an innocent organ like the pancreas is to diabetes. There tends to be, emotional and social overlay to our view of the individual who has this disease of the brain. Addiction is not a disease of the more socially acceptable thinking brain. The motivation to use drugs takes place in a primitive drive building area of the brain, and one cannot think or reason themselves out of the behavior. Addiction is a disease of the survival brain. And if you've been watching the series recently on Dope Sick, you'll understand that individuals reported throughout the film that they felt if they stopped using the opioid that they would die. They felt as if they were dying if they didn't respond to that drive to use an opioid. In the same way that a drive encourages us to drink when thirsty, eat when hungry, and engage in sexual activities when stimulated for procreation and survival of the species. So addiction is a disease of the survival brain. And there's a tremendous disconnect between our thinking brain and our survival brain in addiction. And the survival brain wins over thinking and reasoning ourselves out of the behavior. The survival brain is a non-verbal, emotional, pleasure-driven, survival-driven area of the brain that is not responsive to reason or logic. And often when working with our loved ones, not so much in our professional capacity, but working in our loved ones and trying to convince them not to, say, smoke or drink and drive or use drugs, we want to appeal to their logic. You're going to lose your freedom. You're going to lose your life if you continue to do these things. But the survival brain is telling them that if they don't engage in those behaviors, they're going to die anyway. So we can't think our way into right acting, and treatment requires so much more than trying to think and reason ourselves into right behavior. Next slide, please. The more we know about the complexity of addiction, though, the more effectively we can treat it and then advocate for those with the disease. Next slide, please. So I want to talk a little bit about addiction being a pathology of motivation and choice, and it is a disease of learning and memory. And it is experientially learned. Things that are experientially learned are very powerfully learned and cannot be unlearned. I can tell my 3-year-old child, don't put your finger on the cooktop because the cooktop is hot after I've made your breakfast cereal. And the power of my relationship with them will warn them away. But sometimes they want to test that information and would touch the hot stove anyway. And the learning that occurs from that experience is much, much more powerful and profound than something that they've been taught by a reasonable authority in their life. So this is the pathology of motivation and choice. And the executive control center of the brain is not able to override the drive to use the drug when the pattern of drug using has been set up. Next slide, please. But this disease can be addressed very effectively with treatment. With the opioid use disorder, we know that there is an invisible 80%. Only 20% of the people who have this disease are in treatment today. 80% don't have access to treatment for a variety of barriers. But those who get to treatment and get effective treatment can, in fact, have a profound change in the way they are in the world and, in fact, recover. And that recovery follows abstinence from all mood and mind altering chemicals, except those that are prescribed appropriately for the disease. Sometimes we use medications to help the brain return to, as near as makes no difference, normal functioning. Peer support and professional guidance are important in group therapy and group experiences. The peer support normalizes one's behavior. The professional guidance provides an assessment and analysis that the disturbed or diseased brain cannot provide. Exercise and diet are important to repair and restoration of normal functioning, and ritual brings about a soothing balm and normal activities in the lives of the person who is recovering to support, next slide, achieving the goals of treatment, mental peace, physical well-being, and personal productivity. And notice that when I talk about the result of treatment being mental peace, physical well-being, and personal productivity, I don't report that one of the outcomes of treatment is abstinence, because abstinence is an input towards recovery. You are not going to achieve recovery if you continue to use the substance that is of your choosing. Now, that doesn't, and I exclude from that discussion, medications that are appropriately prescribed and supervised. You can, in fact, recover if you're on methadone. You can, in fact, recover if your physician is using buprenorphine in your treatment and care. But abstinence is one of the inputs to achieving the outcomes of treatment, mental peace, physical well-being, and productivity. Next slide. Now, there are non-medication treatments and medication treatment. Many therapies are effective and helpful, but some only work to a certain point, particularly in an individual whose brain chemistry has been distorted, deranged, or affected by chronic exposure to their drug of choice. And we need to target the non-rational survival brain, just as we do the thinking and reasoning cortex, the executive control center. Next slide. And so treatment is provided in such a way as to soothe the response or the drive to use, reinforce the ability of the executive control center to help a person on a moment-to-moment make a decision that is in their best interest. And sometimes those treatments have to be supplemented with medication. So medications in combination with counseling and psychotherapies may be the best addiction treatment that we have. We treat the survival or pleasure system abnormalities with medications that facilitate abstinence and prevent relapse. So we wean a person off of their drug of choice by substituting things that may not be as reinforcing with a on-off response at the receptor, sometimes allowing that receptor to be in an on position and gradually tapering the medication that's allowed that receptor to be in the on position, tapering or withdrawing or detoxification of an individual. We treat the cortical decision-making system with counseling and other therapies, and we treat the person with soothing balm. So again, I talk about ritual in the life of an individual in treatment can bring about a calming of the disturbance that chronic drug use has brought about, and allow them to be able to put a pause between a thought and an action or using drug, or a feeling and an action of using drugs. Next slide, please. Brain recovery is brought about by preventing the exposure to the drugs, cognitive or thinking rehabilitation, and that cognitive rehabilitation is facilitated with 12-step facilitation therapy, cognitive behavioral therapy, and motivational enhancement therapy. We can use medications and other strategies. Next slide. Such that we see that the overall goal of treatment is to reduce or eliminate the use of alcohol or other drugs as a contributing factor to physical, psychological, and social dysfunction, and to arrest, retard, or reverse the progress of all of the associated problems that are either concomitant with, occurring with, or a consequence of drug use. Next slide. Our current knowledge of treatment is some treatment is better than none, more treatment is better than less, but treatment is best when it's driven by assessment, buttressed with case management, and completed with follow-up care in the community. It is best to know the extent and nature of a person's disease before we apply treatments in order to get the best outcomes, in the same way that an individual with breast cancer would have their breast cancer stage before one makes a decision to remove the lump, follow that with chemotherapy, and follow that with radiation therapy. There are, next slide, a number of ways in which we assess this disorder in order to apply the best treatment. So we identify that there's a problem. We do a brief intervention to drive the individual into treatment so that we can assess them. The assessment develops a diagnosis. In response to the diagnosis, counseling and other medical, psychiatric, psychological, or social services are applied. And then we follow up the individual, and we know from studies of pilots and doctors and clergy that keeping one in treatment over a 5-year period with external support gives us the best outcomes. Next slide. The phases of treatment include a pre-diagnosis where we do an adequate evaluation, history and physical, and get labs. And we want having a partner that allows us to collect this information. We also want to document the disease. We document that there is medically necessary care, how the patient is functioning, and we use standard assessment tools in order to document how they're doing. And around the initiation of treatment, we get a review of the information we've collected and permission to treat that person from a payer. We develop a preliminary treatment plan and match that person to the services. The extent and nature of the person's disease suggests the level and intensity of care that is required for stabilization and then longer term treatment. Next slide, please. Continuing with the phases, the next phase to enter into is treatment. After we've done our preliminary assessment, talked with the payer about what the individual is going to be eligible for, we need to do an admission note and write orders, and we have to have a rationale for what we're intending to do. That rationale is based upon the American Society of Addiction Medicine patient placement criteria. And as a customer of AZZLY, your tools in the electronic health record can be customized to basically write itself, as it can include standard forms in which your individuals, your employees are recording the information that they're getting. So you want to look at for acute intoxication and withdrawal, the pattern of the patient's use. You document using the patient's language about how much and how often they're using. For biomedical conditions and complications, you look at whether there have been consequences of use or whether pain, for example, was the thing that initiated the use. Emotional behaviorally, you want to describe whether there's an imminent threat to the person or others, and then a related condition such as impulsivity or the lack of cortical oversight behavior. If a person lacks cortical oversight to their behavior and are very impulsive, it suggests that they're going to need more around the clock, more intensive observation and care to avoid continuing to use. Next slide. Treatment acceptance and resistance is insight into the nature and extent of the person's disease and evidence or a history of their ability to comply, and it allows a predictive ability to their assessment of a predictive ability of their ability to comply with professional guidance. Relapse potential is made up of skills acquisition and application and symptomatology, which drives the use behaviors and drives the release of symptoms. And the recovery environment looks at the structure in the life of the patient and the support they're getting in their life of their intention not to use. Next slide. And wrapping up, treatment is successful when the individual is able to acknowledge their addiction, commit to recovery, and reduce or eliminate inducements to use. And in your documentation around the care of that person, you want to be able to capture that they know they have the disease, that they accept treatment, that they're working on acquiring skills that are going to allow them to make different choices other than to use when they are feeling a desire to use. Knowing and talking about the knowledge of one's disease is less threatening than feeling. The commitment to recovery is a feeling in the heart, and you want to document the evidence of loss of treatment resistance over time as they respond to the care that's being provided. The commitment to recovery is a heartfelt commitment to not use, and reducing or eliminating inducements to use is assessing over time whether there are adjacent diagnoses that would interfere with that individual continuing to engage in the things that are making them better so that they can become more productive, experience physical peace and physical well-being. Next slide. Next slide. This is all documented in the treatment plan in the chart, which lists the injury, dysfunction, or loss that's being addressed, goals, which guides the resolution of those problems, and the objectives, which are measurable signposts on the way to achieving goals that are part of treatment. Next slide. And it identifies the methods that are going to be used with that individual, where those services will be delivered, and the intensity and duration of those services. It sets out the timeline for achieving the goals and objectives and lays out the length of services that's going to be directly related to the patient's response. Next slide. So that at the end, the person is able to give informed consent, which is documented in the chart of the modalities, risk and benefits, appropriate alternatives, and the risk of treatment versus no treatment. Treatment that's provided, that's been authorized by your payer, can be documented in the chart. It has to be necessary to their health care, and this needs special consideration in the time of the opioid crisis, because if you are going to provide treatment that doesn't include medications, the risk of overdose following treatment that's abstinence-based needs to be discussed with the patient so they can make an informed consent about whether to enter MOUD or not. Next slide. Medical necessity is a legal doctrine that's related to the activities which are justified or reasonable, and with a special note that if you are a provider of services to Medicare, reasonable and necessary may not only pay for the items and services for the diagnosis and treatment of the illness, or to improve the functioning of a malformed body member. Next slide. As we see an individual respond to treatment, we want to continue to assess them along all those 6 dimensions and reassign them in care to continue to keep them engaged with treatment, with a reminder that the admission criteria is more stringent than the continued stay criteria for any level of care. And the discharge criteria presumes progression towards a greater state of health. If there's no progression at an assigned level of care, you may want to consider putting that person into a higher level of care. And finally, next slide. Opioid detoxification alone provides into very high rates of relapse post-treatment, and there are rising rates of overdose due to reduced tolerance after treatment. So in order to fully inform a patient as to what is necessary, one must explore whether the individual should be in an abstinence-based treatment or needs to have the receptor blocked or filled. Next slide. So consideration for the management medication of opioid use disorder is to alleviate the signs and symptoms of withdrawal, block and prevent further use, diminish or alleviate craving, and normalize or stabilize the perturbed brain neurochemistry. Next slide. The most important discussion you can have with the patient giving an opioid use disorder, and we're going to hear in just a minute how the opioid epidemic is affecting us, is a decision as to whether you're going to fix the receptor, fill the receptor, or block the receptor. If you're going to fix the receptor and restore it to as near as makes no difference normal functioning, it requires assisting that person over a long period of time. If you're going to fill the receptor, you're going to take a similar molecule and patch the derangement in the receptor with methadone or buprenorphine, and you can block the receptor such that the person uses again, they're not going to be able to get high. So a competitive blockade at the receptor impedes, obstructs, stymies, or blocks the person's desire to use. So in thinking about if you are dealing with someone with an opioid use disorder and you are going to be prescribing, either filling or blocking the receptor, there are certain conditions that have to get met before you write that first prescription. And so our next speaker is going to discuss with us some of the regulatory changes that are taking place. But making a decision to provide MOUD for opioid use disorder is the most important decision that you can make in conjunction with the patient in a way that provides informed consent about whether or not to have medications used. But once the decision is made to use medications, you are working in a highly regulated environment that requires that you take extra steps to prescribe. So let's have the next slide. And we're going to hear from my colleague Heidi about that regulatory environment. Thank you very much. I'll be around to answer questions.
Thank you, Dr. Barthwell. That was excellent. And that was a perfect introduction to our next panelist, Heidi Polek, who's going to be discussing more on e-prescribing and controlled substance, as well as the prescription drug monitoring program's mandate. So Heidi, take it away.
Thanks, Derek, and thank you, Dr. Barthwell. That was some incredible information. I've been a part of webinars like this for a number of years now, and that truly was, I think, one of the most powerful I've been on. Great information. Next slide, please. So I've been a pharmacist for over 30 years, and I happen to practice in a state where, it was one of the first to institute EPCS and PDMP. So I've been a part of this, for the majority of my career. And I can tell you over time, and speaking on webinars like this, it's really hit me in the heart. The overdose deaths that we are now seeing today. It is at an all-time high. You may have seen some reports out recently about the impact of the COVID-19 pandemic and the impact that it had on patients, limiting their resources for treatment. We are now at an all-time high. Next slide. This is a slide that I've actually spoken to a number of times, and when I first started speaking to it just a few years ago, the number on the slide, it started at 130, so that was 130 Americans a day were dying of opioid overdose. And over time, we were seeing that go down. It got into the 120s, so we were moving in such a positive direction. And then unfortunately, as I mentioned, COVID hit, treatment centers were shut down, patients were not able to get out and see people and meet with their organizations that were helping them through, what is understandably probably the most difficult time of their life. And we are now tragically seeing 190 Americans die each day from opioid overdose deaths. So the treatment options that Dr. Barthwell spoke about, they're extremely important that we get them in place and that we follow the regulations so that we can ensure that the patients get these medications in a timely fashion. If you're not e-prescribing, if you're not checking PDMP, there will be delays in therapy for your patients, none of which I know any on the call want. Next slide. So what is the rationale behind EPCS? As a pharmacist, it was something that I can tell you, I started in pharmacy, there were no computers, and then we got computers. And, every time there's been technological advancements in healthcare, workflow has improved. But there's also other things that this technology can help, one of which was very quick to come to pass was a reduction in fraud, waste, and abuse. Gone are the days when written prescription pads are stolen by patients, fake prescriptions are written and handed off. Believe me, they were very hard to catch sometimes, but I know by getting a prescription electronically, I have the highest level of confidence it is coming from an actual prescriber versus a written prescription. So it does reduce the misuse, not only of opioids, but other medications as well. Believe me, I could go on and on the medications that I saw misused. It reduces adverse events. I can actually read the prescription, and I'm sure for doctors, they appreciate being able to have legible text on a prescription as well. I think the two on the end, the provider efficiency and the patient satisfaction, are really, very important as well. Your staff will be much more efficient by sending prescriptions electronically, and patients are very satisfied with this. Think about it. You're going to be sending the prescription to the pharmacy before the patient leaves your office. It's going to get in the pharmacy workflow. The pharmacy can actually work on it before the patient gets there. If they catch an issue, they can call back to your office before the patient gets there. So problems can be solved before the patient actually gets to the pharmacy to pick up the medication. So there's really a lot of great benefits from using electronic prescribing of controlled substances and really electronic prescribing of any medication. Next slide, please. So how did EPCS come about? Well, it all started back in 2008. And I'd say for myself, not being a legal expert, but if you look at the timeline, things moved rather quickly to put this into place. Within, just a little under 2 years, we had the interim final rule published, and then it was effective, really within 2 years. And I can tell you in New York State, where I practiced, it was very seamless to have the electronic prescriptions flow into the pharmacy. Like I said on the previous slide, workflows became easier for ourselves, for the doctor's office, and patients were they were very happy to get to the pharmacy and their prescription already be ready. You will note that in 2020, they did reopen the interim final rule. It's always good to go back and look at these types of rules that are in place to ensure that we're keeping up with technology and the needs of the providers and the patients as well. So it is open for comment, and we'll see where that goes. Next slide, please. During the COVID epidemic, there have been some waivers. You can understand that there's a lot of regulations in place with the DEA. In most cases, if not all, the patient has to be physically seen by the provider. They can't just be writing prescriptions without ever visiting with the patient. So there have been some waivers in place by the DEA that, relaxed some of the regulations so that doctors could see patients using telehealth. It also assisted with being able to prescribe over state lines. So, sometimes people got stuck in places where they didn't intend on staying because of lockdowns and things like that. So it was nice to see that the DEA was responsive and did put some waivers in place. They are still in effect. My recommendation to you is to always stay on top of any regulation. Always easy to go out to the DEA website, as well as other references that we'll discuss later in the webinar, to ensure that you're meeting all the guidelines that are currently in place. But luckily, patients are getting the care they need while the COVID-19 epidemic is still in place. Next slide, please. There is a new mandate that is coming into place, and this one relates specifically to your Medicare patients. It was called the Support Act, and it is going to be effective. It's actually effective now, January 1 of 2021. The regulation requires that any prescription for a controlled substance for a Medicare patient must be electronically prescribed. The original compliance date where you had to actually start sending them was January 2022, just a few short weeks away. They did move out the compliance date to 2023. Any long-term care facility, it's 2025. But I can tell you, even though they've kind of kicked the can down the road, my recommendation is to don't wait. If you haven't already turned on the EPCS functionality within your AZZLY software, I highly recommend you get it in place now. I can tell you from past experience, and I'm sure everyone on the call, you know the challenges that you see as a new year comes for your patients. Patients are moving off of commercial plans and into Medicare plans. It's hard to tell when your patients are moving to Medicare plans. So don't get caught not being able to prescribe for a Medicare patient because you don't have the technology in place in time. And it's always great to get those things out of the way as soon as possible. So time to get ready for that. Next slide, please. This is one of my favorite slides. It really is a quick snapshot of where these mandates are already in place. You can see the majority of the country is orange, so there is some sort of EPCS and electronic prescription mandate already in place. And you've got some really big, powerful states coming into play in just a few short weeks in 2022. Those are the light blue slides: California, Washington, Utah, Michigan, to name a few. And then another one coming in 2023, and that'll be here before we know it, that's Illinois. And that one is of particular interest because not only is the mandate coming into place, but there will actually be penalties. This is is the first of I've ever heard of something like this, but there will actually be penalties to the EMRs and the facilities who don't have integrated EPCS and PDMP in place. Luckily, you're covered here at AZZLY, working with DrFirst. That technology that you're going to need for those mandates is already in place. Next slide, please. So once again, I don't feel that we can stress enough the upcoming deadlines, especially the one coming January 2022. If you practice in any of the states listed, it's time to get rolling, to get the technology in place so that you can prescribe controlled substances. It's easy like a flip of a switch, but there are a couple things that do take some time, and your AZZLY rep can go over that with you to make sure that you have everything in place to meet everything by the deadline. DrFirst also has a great website. So next slide, please, that you can go to, and I'll show you that in a few minutes. So I want to talk a little bit about what a PDMP is. I know we throw out a lot of acronyms. I've said EPCS multiple times. That's Electronic Prescribing of Controlled Substances. You might wonder what PDMP stands for. That's a prescription drug monitoring program, and those are required by most states. Finally, the last one to put one into place was Missouri, and those are databases of, typically controlled substances. There's at least one state that requires every medication to be in the PDMP. But the PDMP is a great resource where a prescriber can actually see all reported controlled substance prescriptions. And as a dispenser, a pharmacy can also go view this information. And I can't tell you enough how helpful having that information is. And luckily at AZZLY, they have this type of information access integrated into the workflow so that as you're going to prepare the prescription, it's a click of a button to see this information. And I truly can't stress enough, even in the states where it's not mandated that the prescriber view it, in some it's just a recommendation, but as a practice, I would recommend that every prescriber view PDMP data before prescribing, and it is simply a click of a button within your AZZLY software, and you'll see that shortly. Next slide, please. So I talked a little bit earlier about the Illinois update, and I once again can't stress enough that it is extremely important if you do practice in this state that you put your solution in play before the deadline, which is January 2022, to avoid any type of fee. And you are covered here at AZZLY and DrFirst because we have the solution integrated for you. Next slide. Some PDMP successes, Pennsylvania, Tennessee, and Maryland are just a few of the states we wanted to show you where there is actually notable reduction in opioid prescribing. And I can tell you from personal experience in New York State, I saw a dramatic decrease when we went to the EPCS and actually an all e-prescribing mandate. We definitely saw a reduction in opioid prescribing as well as fraudulent prescriptions. So, these are pretty significant numbers. So if you're in a state where a mandate is coming, you too will be able to see these types of benefits. Next slide, please. Here's the website I was talking about. So DrFirst has this amazing interactive website, EPCSgold.com. We have interactive slides that will keep you updated on any requirement for your state regarding EPCS and PDMP mandates. So I highly recommend you kind of add this as a favorite, especially if your state mandate isn't quite into play yet. We keep this updated very regularly, so you can constantly go out and revisit it to make sure that you're compliant with all regulations that are in place. And it's a great, if you're considering expanding your practice into other states, you know, what a great place to go out and find the regulations that you need to follow. Next slide, please. Once again, some more states where all prescriptions need to be sent electronically. So if you're in any of these states, look at that. We've got California and Michigan coming up in just a few short weeks. And I can tell you, you know, I've been on some webinars with California dentists, and they are very quickly adopting solutions so they can ensure that they are prepared for the deadline. Next slide. More mandates by the numbers. We've got 34 states where e-prescribing is already mandated. 6 of the states require all prescriptions, and 8 are coming into play very quickly. So if you're any of those states that I kept showing, please, I can't recommend enough that you get with your AZZLY representative so that you too can be compliant by the deadline. Next slide, please. So in closing, just some best practices. It is absolutely a best practice to be proactive for any type of technology upgrade that you need. EPCS, PDMP mandates, they're just around the corner. Better to do it now than right before the deadline when you're scrambling, because you're already dealing with a lot of, you know, tough times here with your patients. So don't add another, you know, stick into the fire. Consult your state medical society as well as pharmacy board. They are always very up to date on regulations, especially the pharmacies. They're the ones receiving the prescriptions, so they're just as interested in remaining compliant with you in order to be able to fill the prescriptions for your patients. So they're a great resource as well. As I recommended, check your PDMP when you receive a new patient, when you're discharging patients, when you're doing any type of treatment review for your patients. I highly recommend that you check the PDMP. I found some very interesting information about my patients, and I was really able to work through some concerns of mine with the patients. And, you know, and when we did that, I worked with the prescriber and we got the patient the treatment that they needed. And really work out any workflow processes with your staff now. That's why, going back to number 1, be proactive so that all of your staff can be ready to go, and you can mitigate any negative impact that it might have on patient care as you tweak your workflow to meet these new regulations. Next slide, please. Now I'm going to hand it back off to Derek, who's going to introduce our next speaker, Maria, for an amazing demo of the integrated EPCS solution.
Thank you, Heidi. That was fantastic. Really appreciate that, and I know everybody else did as well. We're going to go ahead and move on to our final panelist, which is Maria Gray, and Maria will go ahead and present her screen here in a few moments. And as we're throwing the screen over to Maria, oh, there it is. Perfect, Maria. And I'll go ahead and hand it off to you.
Thank you, Derek. Good afternoon. I'm going to run through a quick demonstration just to go over the single sign-on between AZZLY and DrFirst. So to begin, I'm going to click the right e-prescription button located right here within my medication screen, which, as you can see, will launch DrFirst Rcopia in a new tab that brings over all of my patients' demographic information, their insurance, any medications that they may have had entered within our EHR, their allergies, and diagnoses. So our single sign-on integration provides a seamless synchronization and workflow, allowing you to better manage your patients' medications as well as that full continuum of care between the two systems. Now, you do have the ability to work out of either one of these in terms of entering any of this information, because as I mentioned, there's a bidirectional synchronization here. So any of this information, the diagnoses, allergies, etc., that are entered within DrFirst will sync back to AZZLY, as well as those in AZZLY syncing into DrFirst. So at the top of the screen, I will find my patient's demographic information readily available, including their name, date of birth, and sex. I will also have their address, pharmacy, their prescription benefit information, which will display their copays, deductibles, various tiers of medications, etc. Then down below, I will see any active medications that my patient is currently taking. I do have the ability to review medication history as well. So this would be medication that comes through SureScripts or through the SureScripts database outside of your facility, and you will have the option to view anywhere from 1 month up to 1 year of that medication history. Now that is separate from the PDMP, and the medication history is always available. PDMP is an additional subscription. Again, we have our allergies and diagnoses. So just to quickly go over the process of adding a new medication, I do have the ability to, of course, create a new prescription from scratch where I can search for my medication, the dose, and enter a SIG manually. But we also have the ability to set up favorites by organization, provider favorites, and then also view a list of recently prescribed medications within your organization. So by setting up medications as favorites, you do have the ability to click on a specific SIG that has already been used, which will save time, preventing you from having to manually enter all of that information. By selecting that SIG, my medication is immediately going to be added to my list, ready to be sent to the pharmacy. However, if I do need to make any changes, then I can select the medication itself, which brings me, of course, any clinical alerts. By the way, the clinical alerts, there are several. We have duplicate therapy alerts, age alerts, allergy alerts, drug interactions. And that's just to name a few. Now, I am able to prescribe anyway if I would like to with these medications. We do have some shortcuts as far as some of the possible justifications, or you can enter your own. But after selecting that medication, of course, I can customize my SIG to meet my needs. These are smart SIGs, which is convenient because it narrows down the selections within the drop-downs. So I only have to choose from those options which are appropriate based on the type of medication that I have ordered. Once I have made my updates to my SIG, I can review my medication. Let's enter a day's supply here. Review my medication, where I will be able to see, of course, the medication that I entered, as well as my provider details and the pharmacy that this is being sent to. Once I'm finished entering any of my medications, all I have to do is scroll to the bottom, save my signature password. That will send these medications to the pharmacy. If I would choose to, now I can also choose to print these and not send them. I can sign and not send. So if maybe your patient has some standards that they need to meet before this refill can be made or these medications can be ordered, the provider can go ahead and sign off on these, and then an agent or another user can send the prescription later, which can be helpful. But if I am ready to send my medications to the pharmacy, then by clicking send, those will be sent. And now the medications will be ready for your patient. Now, in addition to the medication management, we also do have the ability to manage prior authorizations within DrFirst, as well as several reporting options, including running reports that are specific to individual medications that have been ordered by the practice, prescriptions that have been ordered by a specific provider, or all prescriptions that have been ordered throughout the practice. Once I'm finished with my work in DrFirst, by signing out, that will allow the syncing to take place for my medications to display within my patient's chart. So now when I view my patient's chart within AZZLY, I'm going to see any prescribed medications that were sent, and I will also find those within my patient's medication tab. Okay. Derek, I can go ahead and turn it back over to you.
Perfect. Thank you, Maria. That was phenomenal. I'm going to go ahead and present my screen then. And thank you again for that, Maria. Again, that was phenomenal. I'm going to go ahead and open it up to questions here. But before I do that, I do just want to do a quick recap and kind of highlight the key points that everyone went through in their presentation. Dr. Barthwell highlighted documentation is key and essential. Heidi emphasized best practice when prescribing and checking the PDMP when it's mandated, and it is mandated. And Maria lastly demonstrated being able to document, check the state PDMP before prescribing a controlled substance. Today's modern technology is the perfect tool to make sure that best practice compliance is being met. So with that being said, we'll go ahead and open it up to questions now, and we'll have our panelists answer appropriately. Okay, we'll give a couple seconds to let some questions pour in. And panelists, feel free to answer these questions as you like. I do have one here. How do I get PDMP is one of the first questions. I'll go ahead and answer that first. If you are a current authorized user of AZZLY, if you do have an AZZLY account, reach out to your AZZLY account manager, and they'll be able to help you out and assist in making sure that you have the ability to go ahead and check the PDMP within AZZLY and DrFirst. That was our first question.
I might add, Derek, this is Dr. B again. I like to take the finding from the review of the PDMP and copy and incorporate it into my note for the day. There is nothing better than the documentation that shows that I've reviewed what that patient had been prescribed elsewhere when I'm writing a new prescription. So there's this ease of integration that you have with AZZLY and DrFirst for that. If you are using some other platform, since the PDMP is provided by the state government, you have the ability to go on there and directly through the state. As a physician or a provider, you can get secondary access to people on your office staff. But having them then bring that into your encounter in the same way that you would bring the previous urine drug testing results or an outside lab that you recorded into that note is the best way that you can document adherence and compliance to these regulations. And so having the integration that AZZLY provides makes it easier. But if you don't have that, you still can go to the state's website and do that review. And I suggest copying it and pasting it into the note so there's no question on a review that you have done what you needed to do and have considered what you need to consider for your prescribing.
Thank you, Dr. Barthwell. A follow-up question to that, which really is intriguing, is what is the difference between medication history versus PDMP?
Well, I know that that was one of the previous slides. So the prescription drug monitoring program monitors controlled substances, and it will tell you whether the patient, when you have to access them by name and other identifiers, has any prescriptions that have been written by any physician in the state. Now, I work in a border city. I'm in Chicago, so I border Indiana. So I have registered in Wisconsin and Indiana for additional information because my patients who might be doctor shopping could actually go across state lines, and you have to register in each of those states. Sometimes they are integrated. But again, having that conversation with your AZZLY representative will allow you to know what's available that's integrated with your record keeping system, the electronic health record that you're using. So the PDMP monitors controlled substances. A medication history generically reviews the history, the medications that one has used. And there are two significant purposes for medication history in providing care for people with opioid and substance use disorders. One is that the history documents the previous use of substances and illicit substances by that individual, puts it in the chart, and it's a part of what you need for documenting the choices that you're making around urine drug testing. The other gives you a sense of what you should be looking at in terms of what a patient might be using when they relapse. So the medication history is extremely important for helping you understand what are the conditions and complications that the person has medically and behaviorally. And it is a slightly more expanded view of medications that the person's been using beyond the controlled substances.
And to piggyback on that just a little also, the PDMP, as mentioned during the slides, is state mandated. So checking the medication history does not meet that standard requirement. So if you are in a state that requires checking the PDMP, then while checking the medication history is beneficial for all of the reasons Dr. Barthwell just mentioned, checking the PDMP is still going to be that step needed in order to stay within your requirements.
Right. One's regulatory, another is, clinical, for better clinical management. I just want to give a little bit of a shout out. I probably in December am going to be doing another webinar with AZZLY that has to do with how does an electronic health record help you document what you're thinking, and sort of featuring the things that are built into the AZZLY system, because it'll be a talk for AZZLY, the things that are built into the AZZLY system that make your documentation easier or more intuitive. So look for an announcement from us in the next couple of weeks about when I'm going to be doing that talk. I like to tell people that I train in addiction services that your chart should write itself. And I know people have a lot of difficulty with documentation, and we have whole systems built up in all of our treatment programs to make sure that our documentation is always kept up to date. But there are lots of little pros that you can learn about how the chart will write itself that will make that part of your life easier. And AZZLY is designed to really facilitate that for you.
That's
Hi,
great.
Derek. This is Heidi. I see a question in the question box that I think I'll take on. It asks if the regulations address what to do when the internet, server, etc. crash. And yes, they do. The regulations understand that there are times when the technology you need to meet the requirements, may not always be functioning. So they do address that. There are exceptions to these types of regulations, but they're very tight. So, and you need to document when and if those occurrences happen. And, in case you are audited, you can show that I did not go out and check the PDMP, or I wasn't able to prescribe electronically because my power was out, my server crashed, etc. There are definitely exceptions.
Thank you, Heidi, for that. And there's another question too, Heidi, that I think you may want to address is how are PDMP delegates managed within DrFirst?
Yeah, so we, keep that. You will tell us who your delegates are, and we are able to put certain functionalities on people and their access to the PDMP. So you do want to ensure that anyone who is helping you in your office as you prepare for your visits, that they have the appropriate credentials to check the PDMP. But I do also recommend, that the prescriber themselves always go into the PDMP. It is great to have people assist you in preparation for your visits with patients, but I can tell you there's nothing like viewing it yourself. We all interpret the data that we see a little bit differently. We see things, something that may catch your eye that may not catch someone else's eyes. So it is very simple. We just need to know who needs the access, and everyone is given very specific credentials to log in. So the PDMP does know who is actually logging in and who is checking, but I leave the ultimate access and checking on the actual prescriber themselves. That's the best place to leave it.
Excellent. Excellent. Thank you, Heidi, for that. It looks like we are coming up to the hour mark for today's webinar presentation. So if there are any other questions, feel free to submit them. Otherwise, you will have the functionality to obviously reach out to myself here over at the AZZLY team or Heidi over at the DrFirst team to answer any more additional questions. I would also like to remind that today's webinar it was recorded, as well as the PowerPoint we could go ahead and send out. If you have any interest, feel free to please email hello@azzly.com to get the link to the PowerPoint presentation. Okay. With that being said, we're going to go ahead and conclude today's webinar. Thank you again to Dr. Barthwell, to Heidi, to Maria. Your presentations were phenomenal, very thought-provoking, a lot of information, a lot of knowledge for all the attendees. Again, to the attendees, thank you for joining today, and we look forward to seeing you again on our next webinar. Thank you very much.
Bye.